So I hope everyone is back already. Welcome to the second part of today's conference. We continue our work. I'm very happy that we heard already a lot of discussion during the coffee break, and I'm sure actually that these discussions will continue also after this session. In this session, we focus on support services for families and also employees. Now, this is the time when I would remind also to have your headphones, because the first presentation will be a personal story, experience story in Latvian language. And this is why I would like to ask here on the stage Inese Lagsdiņa. Inese, where are you? Yes, we will hear a personal story from family member. Inese, mēs gaidām jūs šeit. Paldies.
Labdien visiem! Mans vārds ir Inese, un es šodien mēģināšu jums mazliet izstāstīt par to, kā ir dzīvot kopā ar cilvēku, kam ir šī diagnoze demence. Parasti ir tā, ka sabiedrībā valda tādi stereotipi, ka ir ļoti grūti kopt paralizētu slimnieku, tādu slimnieku, kurš par sevi pats nespēja parūpēties. Es nevienu brīdi nenoliedzu, ka tā tas arī ir, bet gribētu dalīties pieredzē, kā tas ir, ja mājās atrodas tuvinieks ar diagnozi demence. Mēs visi zinām, kad nedrīkst nekādā gadījumā atstāt mājās bērnu vienu pašu līdz 7 gadu vecumam. Viņš nedrīkst atrasties viens uz ielas. Bet, diemžēl, demences pacienta gadījumā tas ir tas pats, tikai vēl daudz, daudz bīstamāk. Es droši vien neesmu izņēmums, un to jums teiks lielākā daļa no cilvēkiem, kas ir saskārušies ar šo diagnozi demence. Tā ir vesela emociju gamma, kas sākas ar absolūti pilnīgu neizpratni par to, kas notiek. Tu vienkārši jūti, kad kaut kas nav tā, kā vajag. Apmeklējot savu tuvinieku, var pamanīt izmaiņas viņu uzvedībā. Lietas vairs neatrodās tur, kur viņas parasti ir atradušās. Bet viss it kā pagaidām vēl ir labi, jo kuram gan nav gadījies kaut ko piemirst, pazaudēt. Tavs tuvais cilvēks it kā tiek galā ar pašaprūpi, pats var iziet pastaigāties un pats var atgriezties mājās. Ja tā ir pirmā reize, kad jūs dzīvē saskaraties ar demenci, tad tu to vienkārši neievēro, jo nav jau absolūti nekas nopietns. Tomēr ticiet man, tas ir sākums. Paiet kāds laiks, citam tie ir mēneši, citam varbūt gads vai pat vairāk, un tu saproti, ka problēma jau ir nopietna. Tu vēl neapzinies, ka pie vainas ir tuvinieka slimība. Tu nespēji saprast, kādēļ cilvēks pēkšņi sāk runāt nepatiesību. Piemēram, mans pirmais šoks bija, kad mēs pēc kārtīgām, ļoti, ļoti labām brokastīm devāmies ciemos pie radiem. Un pirmais, kas tika pateikts tūlīt pēc sasveicināšanās, bija par to, ka ļoti, ļoti gribas ēst. Mēs taču neesam pat brokastojuši. Sākumā liekas, ka tas ir darīts it kā speciāli, lai tevi kaitinātu vai aizvainotu. Bet kamēr šie gadījumi vēl nenotiek bieži, tu vienkārši dusmojies, bet klusē. Tad kādu dienu sāk just, ka arī kaimiņi sāk skatīties uz tevi ar aizdomām. Jo izrādās, ka tu savu tuvinieku neapmeklē, nepalīdzi viņam. Viņam nav ne naudiņas, mājās nav pārtikas. Sākt šādiem cilvēkiem taisnoties un skaidrot, ka tas nav taisnība, ir kaut kā nērti. Un, ziniet, cilvēki arī netic, jo mēs parasti esam pieraduši ticēt vairāk sliktajam nekā labajam dzīvē. Tikai tagad, kad pilnībā es esmu izpratusi visu šo te slimības gaitu, es saprotu, ka rīkoties vajadzēja uzreiz tajā pašā mirklī. Pirmajā mirklī, kad likās, ka kaut kas nav tā kā parasti, jo tad, kad praktiski jau ir zudusi domāšana, orientācija, pat atrodoties mājās, nerunājot par atrašanos ārpus ierastā dzīvokļa, šādu cilvēku vairs nedrīkst atstāt vienu ne uz mirkli. No rīta, pabarojot un apģērbjot cilvēku, nav iespējams doties uz darbu, jo pat pēc pusstundas, tad, kad atnāk asistents, lai pavadītu viņu, piemēram, uz dienas centru, cilvēks jau ir paspējis noģērbties un aiziet gulēt, jo viņš nesaprot, vai tas ir rīts vai vakars, viņš nesaprot, vai ārā ir vasara vai ziema, kā būtu jāapģērbjās. Vislielākās problēmas, protams, rodās ar ēšanu un personisko higiēnu. Visgrūtākais ir tieši ūdens procedūras, un tās tiek veiktas tikai ar ļoti, ļoti lielu pierunāšanu. Par to, ka cilvēks ir paēdis, tiek aizmirsts jau pēc dažām minūtēm. Paliekot mājās vienatnē pat uz īsu brīdi, visu laiku tiek mēģināts kaut ko darīt. Sākumā tās bija neeksistējošu dokumentu meklēšana, tad pazudusi nauda vai vērtīgas mantas. Labākā gadījumā tās ir atvērtas atvilknes, pārkārtotas paslēptas mantas. Sliktākais scenārijs tā ir ieslēgta veļas mašīna, ieslēgta elektriskā plīts, uz kuras tajā brīdī ir nezinu kāpēc novietoti plastmasas trauki. Mājās jums pilnīgi viss ir jāiekārto tā, lai nebūtu pieejamas nekādas bīstamas darbības. Tas ir, piemēram, ar paslēptiem slēdžiem aprīkota plīts, grūti pieejamas, neaizsniedzamas elektroierīces, labi noslēpti asi priekšmeti. Viss tas turpinās tik ilgi, kamēr kādā brīdī tu vienkārši saproti, ka atmiņas traucējumi novērojami jau tādā pakāpē, ka tie traucē ikdienas aktivitātēm un padara dzīvošanu, neatkarīgu dzīvošanu praktiski par neiespējamu. Šeit es pat vispār nerunāšu par jaunas informācijas apguvi, kas bija iespējama slimības sākumā. Pēc tam, diemžēl, pazūd arī agrāk iegūtās zināšanas. Pagāja aptuveni 5 gadi no brīža, kad cilvēks vēl spēja atcerēties jaunības notikumus, varēja noskaitīt bērnībā iemācītu dzejolīti vai nodziedāt dziesmu. Pastaigas laikā varēja atpazīt māju, orientēties tuvākā vai pat tālākā apkārtnē, taču nevarēja atminēties notikumus, kas notikuši pirms dažām stundām vai pat minūtēm. Nevarēja, piemēram, nosaukt precīzu mājas adresi, izstāstīt, kā uz turieni nokļūt, ar kādu transportu ir jābrauc. Mūsu gadījumā visilgāk saglabājās tieši mīlestība pret mūziku. Un ar nelielu palīdzību, atgādināšanu, mēs kopīgi mēdzām atcerēties dziesmu vārdus. Diemžēl slimībai progresējot, visas šīs iemaņas izzuda. Šie aptuveni 5 gadi, ir tas laiks, kad tu saproti, ka tuviniekam ir traucēta domāšana, plānošana, elementāra ikdienas lietu organizēšana. Sākumā tās ir nelielas grūtības veikt ikdienas aktivitātes, sagatavot ēdienu, iepirkties, sakopt māju. Vēlāk tā ir pilnīga atkarība no apkārtējo palīdzības. Sākumā pietika ar uzraudzību, dienas tika pavadītas aprūpes centrā, uz kuru varēja nokļūt pat pati. Pēc tam, kad mēs kopīgi bijām izstaigājuši šo te maršrutu turp un atpakaļ. Vēlāk tas jau tika veikts ar asistenta palīdzību. Tomēr arī šīs spējas, diemžēl, beidzās ļoti ātri. Trakākais, kas bija, radās neizskaidrojamas bailes no pārvietošanās sabiedriskajā transportā. Kā vienīgais risinājums bija visu ceļu ar cilvēku sarunāties, atkārtot vairākas reizes katru veicamo nākamo darbību. Piemēram, tas bija tā, ja mums jābrauc vēl 3 pieturas, tūlīt mēs pārsēdīsimies citā trolejbusā, un tā visu laiku. Ko es ievēroju, ka brauciena laikā nekādā gadījumā nedrīkstēja sarunāties pa telefonu. Tas uzreiz radīja kaut kādu neizskaidrojumu satraukumu, ja, līdz pat ģībšanai, līdz samaņas zudumam. Vissliktākais, protams, mums mājās bija tieši Covid-19 laiks un šie ierobežojumi pandēmijas laikā. Te gan man jāsaka, ka mums ļoti paveicās ar dienas aprūpes centru, jo pat Covid laikā, ievērojot visus ierobežojumus, šis centrs turpināja darboties, un mēs varējām viņu apmeklēt. Pēc manām domām, jau sajūtot tieši pirmos atmiņas traucējumus un ievērojot jebkāda veida dīvainības, uzreiz ir jāvēršas pie ģimenes ārsta vai psihiatra un jāmēģina tuvinieks pierunāt uz šo dienas centra apmeklējumu. Tikai regulāras nodarbības spēja aizkavēt demences progresēšanu, un ir cerība, ka jūsu mamma vai tētis ilgu laiku spēs dzīvot nosacīti pilnvērtīgu dzīvi. Mēs vienkārši neesam informēti par šo slimību un vismaz sākumā nesaprotam, kas vispār notiek, kāpēc māmiņa vai tētis ir kļuvuši par kašķīgu bērnu un kāpēc mašīnas vai dzīvokļa atslēgas, kuras jūs nolikāt uz galda, pēkšņi atrodas nevis ierastajā vietā, bet gan leduskapja saldētavā. Pēc manām domām, tas ir ļoti svarīgi tieši visas sabiedrības izglītošana un informēšana par šiem demences simptomiem un slimības gaitu. Vismaz es pati varu pateikt, ka es nespēju atpazīt problēmu pašā sākumā un sākt darboties tad, kad šis efekts būtu bijis vislabākais. Mēs visi zinām, cik svarīga ir sabiedrības vakcinācija, agrīna vēža diagnostika, bet mēs neesam informēti par demences agrīnu noteikšanu. Ieraudzīt tieši pirmās pazīmes varam tikai mēs, tuvinieki. Pats cilvēks aizejot pie ārsta vienmēr apgalvos, ka ar viņu viss ir labi, viss ir kārtībā, viņš pats veic visus mājas darbus, viņš visu var un visu spēj pats. Tikai mēs, tuvinieki, redzam, kas notiek īstenībā. Uzmanība pēc manām domām būtu jāpievērš arī demences slimnieku tuvinieku izglītošanai un informēšanai par šo slimības norisi un atbalsta sniegšana viņiem, lai mazinātu tieši izdegšanas risku. Kopt demences pacientu ir ļoti smags uzdevums. Ir nepieciešama ārkārtīga pacietība, lai nedusmotos par vieniem un tiem pašiem jautājumiem, lai nedusmotos par pazudušajām mantām. Noteikti ir jālūdz palīdzība saviem tuviniekiem, protams, ja tādi jums ir. Ja. Vai vienkārši, ja viņu nav, tad apkārtējiem vai profesionāļiem, jo bez šī atbalsta izdegšanas risks ir ļoti, ļoti augsts, un tas apdraud ne tikai kopšanas kvalitāti pašam šim demences pacientam, bet gan arī pieliek punktu paša kopēja karjerai un pat iespējai strādāt jebkura veida darbu. Jo jūs taču saprotiet, jūs nespējat pat elementāri aiziet uz veikalu iepirkties, kur nu vēl doties uz darbu, ja tajā brīdī mājās nepaliek kāds cilvēks, kurš uzrauga šo jūsu tuvinieku. Un kā risinājums, protams, ir dienas centra apmeklējumi, kas ir ļoti pozitīva lieta, ja, un pēc manām domām, kas palīdz visvairāk. Tas ir risinājums līdz tam brīdim, ja, kad jūs savu tuvinieku, diemžēl, esat spiesti ievietot jau ilgstošas aprūpes iestādē. Tas, pēc manām domām, ir ļoti sāpīgs brīdis. Un šim brīdim cilvēks vienkārši nav gatavs. Tu ar prātu saproti, ka tas ir jādara, bet ticiet man, sirds saka kaut ko citu. Pietiek ar vienu gaišu mirkli, pietiek ar skatienu, ja, kurš pēkšņi vienā brīdī noskaidrojās, un tajā var saprast, ka tevi atpazīst un mīl. Kaut gan vēl 10 minūtes atpakaļ tika uzskatīts par svešu cilvēku. Ar to samierināties ir ļoti grūti, un šeit ļoti ir vajadzīgs atbalsts. Kaut vai apspriesties, aprunāties ar tādiem pašiem cilvēkiem, paklausīties, kādas ir viņu problēmas, kā viņi risina šīs te problēmas. Mums latviešiem ir tāds teiciens, dalīta bēda ir pusbēda. Un varbūt, protams, es runāt par to varu ļoti ilgi, ja, un diemžēl te ir vairāk šī te negatīvā kā pozitīvā, bet nobeigumā es gribētu uzsvērt varbūt dažas pēc manām domām galvenās problēmas. Ļoti sarežģīti ir iegūt invaliditātes grupu šādiem te slimniekiem tieši slimības sākotnējā stādijā. Tajā brīdī, kad šī palīdzība būtu visefektīvākā, bet bez invaliditātes grupas nav iespējama, piemēram, asistenta piesaistīšana. Ir jādara viss, lai panāktu vismaz otrās grupas piešķiršanu, jo tādā brīdī pienākās asistents, bet ar viegliem kognitīviem traucējumiem, diemžēl, piešķirt tikai 3. grupu, un 3. grupai asistenta vienkārši nav. Vēl, protams, dienas aprūpes centru pieejamība, un vairāk gribētos, lai cilvēkiem ir zināšanas, kā uz šādiem centriem nokļūt. Vajadzētu vairāk informēt sabiedrību par iespējām, cik var agrāk noteikt diagnozi, lai jūs varētu regulāri vadāt šo te savu senioru uz dienas centru, tieši uz nodarbībām, un pats normāli, pilnvērtīgi turpināt strādāt. Nevis gaidītu to brīdi, kad vienīgā vajadzība ir tikai aprūpe un uzraudzība. Un, protams, pēdējais ir diezgan garās rindas uz šiem te diennakts aprūpes centriem, un, protams, arī finansiālais aspekts, jo ievietot savu tuvinieku tiešām labā un kvalitatīvā vietā, tas, diemžēl, ir ļoti dārgi. Tas būtu arī viss. Paldies par jūsu uzmanību, un es ļoti ceru, ka varbūt kādam šī informācija bija noderīga un ļāva kaut ko pārdomāt. Paldies!
Paldies, Ines, par šo stāstu, par drosmi un spēku dalīties tajā, un arī par konkrētajiem ieteikumiem un arī aktualizēšanu dažādu aspektu. We continue our conference with also one other presentation about how to prepare relatives with life with dementia patients, but if you have questions to Ines also, please prepare them for later. After the next presentation, we have the time slot for question and answers, also either using Slido platform or just raising your hand. And now I would like to give a floor to Laura Rautiainen, the Finnish Association for the Welfare of Older Adults. Representing this association, Laura Rautiainen is a regional coordinator for the Circle of Couples Intervention, Empowering Self-Management at the Finnish Association for the Welfare of Older Adults. She holds master's degree in health science and is a doctoral researcher at the gerontologist by training. And please come here and tell us more about the Empowering Self-Management group intervention at the early stage of dementia, please.
Thank you. Dear participants and dear colleagues, I would like to start by giving you the story by Finnish experts by expertise I'm trying to get the video opened. Just wait a moment.
Me ruvettiin ihmettelemään, tai minä rupesin ihmettelemään sitä, että miten näitä tietyt tavarat menivät aina väärin järjestyksiin.
No, mä voin sen verran kertoa tästä vähän alkuun, että silleen tosiaan havaittiin tämä, että Leenalla oli tuommoista niin kuin joidenkin tavaroiden niin kuin nimeämisongelmaa, tai että jos hänelle sanoi, että annapa kaupa, niin hän saattoi antaa jonkun ihan muun esineen. Ja se tuli joskus kesällä aina ilmi, kun tehtiin jotain ruokaa porukalla. On useampia vuosia.
Olisiko 3 vuotta jo aikaa siitä?
Niin.
Tai ainakin lähes sen verran. Ja kyllä sen huomasi heti, että jotain on vialla, kun minä olin aikaisemmin aika tarkka, että tavarat oli järjestyksessä ja nyt ne yhtäkkiä olikin ihan missä sattuu, että kattila löytyi kuulemma jauhokaapin takaa ja niin edelleen. Ja kun kaikki rupesi ärsyttämään niin paljon ja minusta tuli vähän niin kuin vihainenkin siinä vaiheessa, niin sitä ihmeteltiin sitten. Mutta siellä oli ihan niin kuin fyysistä ongelmaa, että korvissa suhisi esimerkiksi. En mä mistään, kukaan ei osannut sanoa, että mistä oli kyse, enkä mä osannut kyselläkään mistään. Ja sitten me käytiin myös tuolla silmälääkärissä, koska mulla rupesi olemaan niin silmien kanssa jotain ihmeellistä oiretta, että jos mulla oli tavaroita työpöydällä, niin mä en löytänyt niitä sieltä. Mä taputtelin pöytää ja tunnustelin, että missä nyt on kynä. Ja se herätti sitten jo enemmänkin huomiota, että silmälääkäri totesi, että tässä ei ole mistään sellaisesta kyse, että täytyy mennä jonnekin muualle. No, vaikea oli uskoa sitä koko tilannetta, että niin kuin Timo sanoi, niin kyllä meidän vanhemmat oli näyttäneet mallia, että miten sitä eletään muistisairaan kanssa. Että selvitettiin sitä, mutta täytyyhän se sitten hyväksyä, kun se tuli näissä testeissä esiin.
Niin, mä muistan semmoisen ensimmäisen testin, kun siinä kaikki varmaan tietää, että siinä piirretään kello. Ja Leena oli tehnyt ne testit ja ne oli mennyt ihan suht hyvin, ettei oikeastaan niistä testeistä ei olisi mitään seurannut. Mutta sitten tuo muistihoitaja sanoi mulle, että katsopa tätä Leenan piirtämää kelloa. Mä katsoin sitä ja sanoin, että niin, että mitäs siitä pitäisi niin kuin ajatella. Niin hän sanoi, että etkö sinäkään huomaa, että ne numerot on siinä kellotaulun ulkopuolella. Mä sanoin, että no joo, tosiaan. Että se on vähän niin kuin Leenalle kyllä tyypillistä, että se on hutassut on.
Taiteellisesti.
Niin se vähän näin, mutta itse asiassa se oli kyllä hyvin olennainen huomio siinä tältä muistihoitajalta. Mutta en minäkään huomannut siinä piirustuksessa mitään ihmeellistä. Ja tässä onkin niin kuin jännää se, että ne muistitestit meni hyvin, seuraavatkin muistitestit meni ihan hyvin. Ja vielä seuraavatkin meni erittäin hyvin. Jos niiden muistitestien perusteella olisi jatkettu, niin Leenalla ei olisi mitään lääkityksiä vieläkään. Sitten vasta niin kuin hetken päästä niin geriatri sitten, olisiko mitään, niin kuin Leenalla mitään sitä vastaan tehtäisiin noin tuommoiset selkäydinmerkkiäänetestit ja sitten päänkuvaus oli jo tehty ja siitäkään ei muuten seurannut mitään. Se on ihan normaali se. Nämä on aika mielenkiintoisia sille, että se ei välttämättä kaikilla niin kuin jää niihin seuloihin, muistitestiseuloihin ollenkaan.
Mulla oli semmoinen haaste, että mä lopetin autolla ajamisen. Sitä ei olisi tarvinnut tehdä, mutta tuli todella yhtäkkiä niin outo olo
siellä autoratissa, että miten mä uskallan lähteä enää. Epävarmuus. Joo,
Joo. Se on nyt semmoinen tyypillinen oire tässä. Ja mitä nyt niin kuin tuttuja on saatu tämän muisti-ihmisten ympärillä, niin kaikilla on semmoinen niin kuin voimakas epävarmuus. Ja se oikeastaan niin kuin leimaa sitä arkea aika paljon.
Mutta muuten kun ajattelet, niin eihän meillä mitään erikoista ollut, erikoisia muutoksia on tullut. Me eletään kyllä ihan samanlaista elämää kuin aikaisemmin.
So there you heard the story by our experts, by expertise, and I would also like to thank Inese for sharing her story. And I think by these stories we are at the heart of this whole happening. We need to listen for the voices of people with dementia and their loved ones. My aim in this presentation is to inspire hope, to stimulate ideas about empowering group, and then also to inspire to think about older adults' own expertise that we really should take notice of. And I would like to quote participant in Circle of Couples group. I am grateful that we were able to join this group. My spouse's memory disorder is in a very early stage. The best thing about the group was the useful information and peer support. This group made me feel safe. It is possible to live a good life with memory disorder. And this is also something that Leena and Timo said. They say that their life is still the same. It may be a little bit different. They need to take notice of some things, but in the end, the life is still the same. And we already heard from Pia Pulkkinen about the memory disorders in Finland. And I would like to add that early diagnosis, timely treatment, person-centered care, and self-management skills are really important in the early steps in the memory pathway. And I also think that we should notice both people with memory disorders and their spouses, partners, other family members, close people. And they are all in the same boat. We need to help them to row in the same direction, as Pia said earlier. And Circle of Couples is based on a randomized controlled trial that was conducted in Helsinki, Finland in 2011 and 2014. And according to this study, we got really good results. The Circle of Couples group model, it improved the cognition of people with dementia, and the results could be seen in the verbal fluency and also at the clock drawing test. And for the spouses, it improved the health-related quality of life, and there we got a clinically significant result. And for both of these, for people with memory disorders and their spouses, the results were still visible up to 6 months after the facilitated group process had ended. And it's also been seen from the cost effectiveness side, and we took care of every social and healthcare costs, and it didn't increase overall costs, so it's a cost neutral. But if we could address even earlier point in the memory pathway, I think it's possible to save money with group interventions. And so what is this all about then? It's an evidence-based group intervention. It's developed by the Finnish Association for the Welfare of Older Adults. And we think that older adults are the best experts in their own lives. And this group consists of around 10 older couples who both participate in the group. They are participating together and they both get the information and peer support. And the group is facilitated by a team of 4 trained facilitators who lean on client-centered approach, they are goal-orientated. They also encourage to think about the empowerment, and they help to identify the self-management skills, and then also to give information tailored according to the needs of the participants. So it's a closed group model, and it aims to improve the well-being and self-management skills of both people with dementia and their spouses or partners. The group meets 8 times in 2 months period, and one group meeting is usually around 3 or 4 hours. And it's a closed group, so when the group begins, no more members are added to the group. And the main asset of the group are the participants themselves. We think that it's really important to take in considerations their needs for information, their need for peer support, and we need to meet the expectation in the group. And to ensure this, the facilitators are interviewing every single participant before the group begins. And that's how we get to know what kind of needs they have for the information and what kind of other wishes they have. And the interview is also a good point where you can start to really look for the empowerment side as well, to think about what kind of relationship they had, how did the couples meet, what kind of things they like to do in their free time. And then the group facilitators, they write an empowerment letter that is being given to each participant before the group begins. And this is something that we do to make visible all these aims for the group, the need for information, and also need for peer support. Oh, and every participant is being trained by the Finnish Association for the Welfare of Older Adults, and every facilitator is participating in every group meeting. Here in the right-hand side, you can see the picture. It represents how the Circle of Couple group is organized. It has the 8 meetings. It begins with the interview, and then hopefully the groups continue meetings independently without the facilitators. And the gray area on the bottom, it's the role of the group facilitators. And the facilitators, they take little steps down so that the participants in the purple area, they can meanwhile take steps forward. So their empowerment grows and their self-management skills are also growing. And it has 3 parallel group processes that go on in the same time. The line in the middle, it's the Circle of Couples group, where all of the couples are together. And in the Circle of Couples, you can see things. The other couples are sort of like a lens. You can see through different windows, different ways of being a couple who is facing the life with dementia. But then there is also need for individual support. So we have groups for people with dementia in the top row. They like to discuss about worries related to getting the diagnosis, and also they usually share practical tips about how they live their lives, what kind of good things they have found in their own mundane day-to-day life. And then the spouses or partners, they usually talk about their feelings. They ventilate about what kind of worries they have towards the future, and also they like to share information and think about the ways how they can make the life together as good as possible. And we think that the relationship between the couple, it's really important. It's actually one of the key resources we need to consider. And then the hope, I think that because we know that dementia, there is a lot of stigma which can then make life a bit difficult. We need to change the outlook from hopelessness into awakening hope. Because by the studies, we know that hope is a factor that may reduce the levels of depression, anxiety. It can improve the quality of life, and it can also improve the subjective well-being. So therefore, I claim that hope is the key ingredient for a good life with memory disorders. And according to a study, the Circle of Couples group may increase hope and also foster a sense of continuity in life. So they feel like life goes on, we can live a good life. And also participating in the Circle of Couples group may enhance self-management skills of both people with dementia and their spouses or partners. The average age of when participants are coming to Circle of Couples group is around 76, 78 years. And most of the participants who have received the diagnosis, they are males, and the spouses or partners, they are most likely females. And usually the diagnosis, they have received it around 1 or 2 years before entering into the Circle of Couples group. Here is an picture where you can see factors that are associated with the life satisfaction at the Circle of Couples group, and also some rehabilitation pathways towards older couples' life satisfaction. And this information is based on a survey from participants in 2020 and 2021. And here you can see that life satisfaction of these older couples was positively correlated with meeting other people, feeling safe, and being satisfied with relationship. And here again, discussing about memory decline with your own spouse was one of the most important things. And participants say that they have not really discussed about receiving the diagnosis or actually planned the life ahead before the group. And in the group, they understand why they should take the action, be active, and plan their own life ahead. And these 3 parallel group processes in the Circle of Couples is the thing that enabled ventilating the feelings and gaining information. Here you can see some feedback from the Circle of Couples group. And most of the participants, they are really, really satisfied with the group, and actually they hope that, I wish that everyone who receives the diagnosis could enter into a Circle of Couples group so that they can also get the information, be empowered, and learn to address their self-management skills. Most of the groups, they continue meetings with each other after the facilitated group. More than half of the groups actually continue as a group without the facilitators. And this is a really important thing because the facilitators can start a new group, and meanwhile the peer support and information, it continues, it carries on. So it's really important to think about the self-management skills and the ways you can promote people's own mastery and being in charge of their own lives. And in the end, I would like to make a point about one important thing, because now we have really good information about the Circle of Couples group model, but we know that number of people who are living alone without a spouse or partner in the same household, that's, at least in Finland, it's increasing rapidly, the number of people living alone. And also we are getting more people with dementia who are living alone in their own homes. So we need to start looking for the ways to find the self-management skills and empower these people as well in the early steps in the memory pathway, so that they can actually take charge of their own lives and start to think about the future. In the Circle of Couples group, they usually want to receive information about nutrition, being physically active, how to think about the legal documents, what kind of things, continuing power of attorney, for example, or what kind of needs they have towards the long-term care, how to make the steps smaller so that it's easier to actually move from one stage to another. So this is something new that we have now started to think about the people living alone. But in the end, I think that here again, the person themselves, they are the most important thing, and we need to listen to the voices of older adults. So that was it. Thank you.
Thank you, Laura, for your presentation. Now we have time for questions. Maybe already for Laura you have questions. So I don't know, maybe Laura, you feel more comfortable to answer from here or from your seat, okay? Yeah, okay. Do we have questions to Laura from audience, first of all, and then afterwards we switch to Slido? Maybe until we still are searching for the hands, please raise your hand if you are ready to ask. May I ask you, we mentioned in the first part of the day that there is a problem when person with dementia are refusing to cooperate and don't want to go to these centers. Do you see something similar at the beginning with these couples, like maybe the person with dementia doesn't want to come to join these circles, and the spouse or the partner need to, I don't know how to work with this dementia patient to then later come together to these circles?
Thank you. It's a good question. Actually, I think that in the circle of couples, it's really important that both the people with memory disorder and the spouses, they are both willing to join the group. They need to be wanting to be in the group, because group is not for everyone. Then you also need some individual therapy or individual guidance if the group is not for you. But I think that one of the things that makes the couple feel welcome in the group is being met by the group facilitators. They can discuss about things, they get information, and they get the choice. They can think about it, and they don't need to come to the group. They don't need to say yes immediately. They can think about it. And sometimes the time might not be right at the moment, but maybe 6 months later the couple is then willing to participate, and they really want that. And in Finland, we have really good system. Usually the couples, they come through memory clinics, memory nurses or geriatrians. They talk about the Circle of Couples group to their patients, and then they get the information at that point. They get time to think about it, and then when the facilitator contacts the couples, they are then already processed about the information in a bit. And in the groups, we also talk about how to address your own needs. For example, in the spouses group, what is the right time to take help, accept help into your own home, and how to recognize your own needs in order that you don't let yourself get too overburdened. And also sometimes the spouses think about, do I want to be the informal carer? Do I want to take this role? But at the meanwhile, they also think about, well, if I don't take that role, then who is going to take and step in? But I think that it's really important that you get this opportunity to discuss about these things. And also for the people with dementia, they are also thinking, I don't want to be a burden for my wife or my partner. I don't want to do that. I don't want to make their life difficult. So what can I do to myself? Can I be more active? Can I plan things with my spouse? So they are both in the early stage. They are thinking about and making a plan towards the future. And I think that is maybe helping to adapt and cope with the life with dementia.
Mm-hmm. Thank you. Maybe some other questions. First of all, from audience. Yes, please.
Jā, paldies par prezentāciju. Jautājums tāds, tātad vai es pareizi sapratu, ka organizē veselības aprūpes iestādes, vai tas ir geriatrijas centrs?
Es atvainojos, varbūt mazliet ļausim Laurai uzlikt austiņas, lai dzirdētu tulkojumu jūsu jautājumu. Tūdaļ. Ready? Yeah.
Tātad mans jautājums ir, kas organizē šīs te pāru tātad terapijas grupas un kas finansē šīs te aktivitātes? Es sapratu, ka it kā veselības aprūpes iestādes vai geriatrijas centrā tātad tiek veidot šīs te pāru aplis vai varbūt arī kaut kur citur un kas finansē šīs te aktivitātes.
Jā, paldies. Tādēļ pagaidīsim tulkojumu un are you ready to answer?
Yes, thank you. That was a really good question. Actually, Finnish Association is an NGO and we get funded by the Social and Health Ministry. And we don't have our own groups. We train the facilitators. And facilitators, they may come from different backgrounds, for example, well-being counties or different organizations, for example, Alzheimer's Association or informal care associations. And sometimes we have really good examples when different organizations work together. So there are a couple of facilitators from the health well-being country and couple facilitators from the Alzheimer's Association. And then these different organizations, they combine their resources and it creates less tension for limited funding or things like that. But for the participants, the groups are free of cost. They come there on their own car or public transport and they pay for their own coffee or meal if it's part of the group, but otherwise the group itself is free of charge. So most of the cost that comes for different organization is the time and resources for the place of the group and then also for the time of the group facilitators. And we also have most of the facilitators, they are social and healthcare professionals, but we also have a couple of volunteers who want to be part of this group activity. Did I answer your question?
Saņēmāt atbildi uz jautājumu?
Paldies.
Jā. Vēl viens jautājums, lūdzu.
Ja, es gribētu pajautāt iepriekšējai runātāji Inesei, ja viņi ir?
Jā, Inese, es gribēju tieši atgādināt, ka Inese arī var uzdot jautājumus. You can also ask questions to Inese, previous speaker as well. Inese, vai tiek nodrošināts? Bet jūs latviski jautāsiet.
Nu, Inese latviski, jā.
Inese, vai jūs
mums
ir
tulki, jāizmanto pa visu naudu. Paldies tulkiem. Es gribēju pajautāt, tieši sasaistot abas divas runātājas, kā Ines vērtē vai Latvijā vai Rīgā, droši vien no Rīgas, cik tuvinieki paši ir gatavi, teiksim, veidot šādas vai iesaistīties, ja būtu tādas atbalstu grupas, iesaistīties šādās aktivitātēs, jo patiešām mums, vismaz man tāds iespējas ir radies, tas primārais fokus ir uz to, teiksim, slimības, jeb problēmas skarto cilvēku un varbūt mazāk uz atbalstu tuviniekiem. Kā Ines vērtē, cik tuvinieki būtu gatavi iesaistīties vai no atbalstu grupās vai, teiksim, vairāk vai mazāk profesionālās, vai mazāk profesionālās vai profesionālākās atbalsta grupās. Es šeit vairāk arī jautāju no tāda viedokļa, vai būtu tāds kā iedzīvotāju pasūtījums publiskajam sektoram kaut ko darīt šajā virzienā, kā viņi vērtē. Varbūt ir vēl kāds cits, kas arī var šo savu pieredzi pastāstīt, cik cilvēki gatavi.
Jā, paldies par jautājumu. Inese, kur jūs esat? Es neredzu Inesi. Nē, jā. Inese, vai jūs esat pie mikrofona? Tad lūdzu vienkārši slēdziet mikrofonu. Man likās, ka beigās. Varbūt ir kāds cits. Jā, lūdzu, šeit ir paceltā roka.
Es gribēju arī paturpināt šo tēmu. Paldies arī par jautājumu, paldies par prezentācijām un stāstiem. Žēl, ka Inese ir aizgājusi, bet es pārstāvu arī līdzīga tipa dienas aprūpes centru, kas ir arī Ineses darba vieta, bet tātad mūsu dienas aprūpes centrā mēs rūpējamies ne tikai par klientiem, bet arī par viņu tuviniekiem, un es ik pa laikam saņemu jautājumus, vai ir kaut kādas atbalsta iespējas tieši tuviniekiem, un arī, kamēr Laura prezentēja tās pašpalīdzības grupas pāriem, man arī radās iekšēji doma, ka vai to nevarētu paplašināt arī uz vecāku bērnu grupām, jo bieži vien tieši bērni ved savus vecākus uz šādiem dienas aprūpes centriem. Un es nebiju iepriekš varbūt aizdomājusies, ka būtu varbūt arī liederīgi un palīdzoši tās grupas veidot, iekļaujot šos cilvēkus ar demenciju, jo nu, parasti tās atbalsta grupas ir tieši tā kā atsevišķi tuviniekiem, lai sniegtu to atbalstu, bet arī, kad būtu tāda sadarbība kopā bērniem vecākiem vai vīriem, sievām un līdzīgi. Šobrīd vismaz mēs pamatā strādājam individuāli, sniedzot atbalstu, jo grupām vai nu nav tāds kopējs vienots laiks, vai mums ir arī mazliet valodu jautājums aktuāls, tad būtu latviski, krieviski. Līdz ar to šobrīd varbūt mums nav šis atbalsta forma tā ļoti izvērsta, bet es domāju, ka tas ir virziens, kurā domāt un ko varētu attīstīt noteikti arī tālāk.
Paldies! Varbūt ir šeit klātesoši vēl kāds ar līdzīgu pieredzi, kas varbūt vēlas ko komentēt pie gan jautājumu, gan jūsu atbildes. Maybe someone with also other comments or questions.
Manuprāt, tādā gadījumā būtu arī jāorganizē šo te grupu koordinātoru apmācība. Jo mēs nevaram tā vienkārši iedomāties, ka mēs tagad vadīsim tādu grupu. Tad tiešām ir ļoti jāizprot tā specifika un arī jāapmāc tie koordinātori. Vai tas notiek tā arī Somijā?
Paldies par jautājumu.
Sorry, can you...
About this, if these people who work in these groups, are they educated or trained enough in Finland as well?
For the Circle of Couples group, we train the facilitators, and the training model, it lasts about 6 months, and it includes both 5 training days and then also facilitating your own Circle of Couples group. And we think that combining the theory and then also the experience from the group model, it helps to sustain a good quality that we have had since the randomized control trial. So we ensure that all these key elements are present in the groups so that we can inseminate the evidence-based group model with good quality. So I think that training the facilitators is one of the first steps. You need to do that really well in order to get good quality group activities.
Laura, do you have experience with training some facilitators from other countries? What if some Latvian interested organizations would approach you, or Lithuanian, or Estonian? Estonia has already their own way, but...
Yes, in Circle of Couples we haven't yet trained facilitators for other countries, but we have another group intervention, Circle of Friends, that has been developed by the Finnish Association for the Welfare of Older Adults, and it's actually been selected among the European Union best practices in the field of mental health, and that is something that we have already been training to another countries, so I think that is possible. We just need time. It doesn't happen overnight, but it's good to start preparing right now in order to have the group model, but I think it's possible, yes.
Thank you for question. Some other question from audience? Or do we have something in Slido as well? Online questions?
Yes, one question from Slido. I have noticed that Finnish Circle of Couples has an empowering approach. What kind of tools for empowerment would you suggest for the older participants?
I think that the most important tools are information and asking from the participants, because you need we always talk about that if you get the information from the book or from a person who is coming to give a speech or lecture, you can only take in so much information. And if you only get the information, it doesn't really lead into anywhere. So you need the time to chew the information and think about it and discuss about it. And you also need to think about what kind of needs you have for information. And by self-management, you need to think about your own life situation and think about what kind of needs do you have. For example, is your nutrition in a good way? Do you need to maybe make some changes? Has the food been quite in one-sided, or do you maybe not go to different places, or are there some issues with the social relationship? You maybe don't have any friends or anyone to talk to with. So maybe I think it's one of these things in the finger mode as well, the key ingredients in a good life with living life with dementia. These are the self-management skills that you learn to think about for yourself, and then you take action, start planning for the future. So these kind of tools.
Do we have other questions?
No, that was it.
Okay, thank you. Still last chance in the audience to ask questions now. If there is some hand, please let me know. If no, we are just going through the next presentation, and we are switching to caring for employees segment of this conference, and we will talk about the use of culture in caregiving in long-term care institutions. And this presentation will be given by Marit Stranden, CEO of the Norwegian Research Centre for Arts and Health. Marit is also a visiting associate professor at the Norwegian University of Science and Technology. And with a background in research, teaching and management, her focus has shifted from neuroscience to public health, particularly the role of the culture and quality of the life and sustainability. So Marit, please, the floor is yours. And after Marit's presentation, we have again time for question and answers.
Thank you so much for inviting me to come and share our experience, and it's been so interesting to listen to the other speakers today. I thought I should start just by the research space, since there is increasing research evidence on the health promotion effect on art. So we have the scoping review, which you probably already know from the World Health Organization in 2019, aimed to summarize the knowledge of the global evidence on the role of the arts in improving arts and health and well-being. And in general, it appears that our mental health and well-being can be positively affected by the engagement. And the arts activities can be interventions combining components that are known to be health promoting, and may trigger psychological, physiological, social, and behavioral responses that are causally linked with health outcomes. But the research was limited to English and Russian papers, so it lacked research from other languages. And often the practice-based results are often published in mother tongue from the practitioner field. So the year after, Scandinavian Scoping Review added examples of arts and culture activities that are used for improving mental health, like dance, music, arts on prescription, visits to museums and galleries, visual arts, literature, theater, and so on. And the research suggests that art engagement is important for mental health and well-being throughout life. So the same outcome. And two of the authors was also the editors when we started the Open Access Journal, with the Research Centre established also in 2019, which aims to strengthen arts and health field. It's free to publish there, both for researchers and for practitioners. So please help us provide the Nordic politicians and decision makers with evidence-based policy making. And the journal was based on a Nordic collaboration and is open for researchers and practitioners. And the same collaboration have initiated this Nordic Arts and Health Research Network which we invite more members to join if you are interested. And the Hunt study of Norway is one of the partners of our center. There exist population-based health studies in several countries, and this is from the county where the center lives in Norway. It has a high % of adult population reporting every 10 years since 1984, and cultural question was included in the second round in 1995. And results from association studies described that individuals who were culturally active experience better health, are more satisfied with their lives, and experience less anxiety and depression than individuals who were not culturally engaged. And furthermore, individuals who were culturally active had lower overall mortality risk than individuals who were not culturally engaged. So I have convinced you now that culture is important. So our center is anchored in political papers. And I think we are a bit unique that we are the health ministry supporting us to work with culture into the health sector. We were appointed in 2014 by a white paper of care exploring new non-pharmacological tools to solve challenges in the field. And we are now 10 years, so we will celebrate this with a seminar the 19th November, which will be streamed, but it will mostly be in Norwegian. And in the national budget from 2015, they proposed to develop and disseminate an educational program in music-based caregiving to employees of the healthcare system. This is a tender project, which we now have for the second tender round, administered by the Norwegian Directorate of Health. And it's part of the governmental strategy to increase competence in the field of health and care. And it's belonging to the strategy to recruit, keep, and develop personnel. Both the center and this national education program was described in the white papers of elderly care, and to develop new systematic cultural measures to improve health and well-being among users of health and care service. The last white paper focused on how to live safe at home, which connects to the other presenters today, but you should stay home as long as possible. But in addition, we are also mentioned in the public health white papers. In the 2018, it was mentioned together with Association with Youth Health, which you also work with, and the recent paper from last year on mental health. Then mental health is one of 6 main areas and describes the center and educational program for this strategy area of improving mental health and quality of life. And we have the public campaign, which is research-based on ABC for good psychological health as a national pilot. You should act, you should belong, you should commit. If you do that, then you strengthen your mental health. So the aim of our center is to develop and teach culture-based measures to promote health and well-being and facilitate the interaction between research, education, and practice within the fields of culture, health, and care. And our primary target group is the employees in health and care system in the municipalities, and the methods are developed for persons with dementia diagnosis. But we see that it works for employees who work with users and patients of all ages and with all various diseases and disorders. Our staff at the center are about 5 positions altogether, with changing guest researchers. Now we have a researcher in arts and health and performing dancers. And we have assistant professors who teach in the educational program together with the administrators. And we have external lecturers coming from the practitioner field, which helps us with the teaching. So the music-based care program to use music for health benefit is nothing new. I guess you already use a lot of music in your practice, but how can we broaden the use and how can we implement it into our healthcare system? So this national education program has passed 7,000 participants this year, which we have been teaching in the different courses. And why music, since we are working with culture in general? Music activates the entire brain and mobilizes resources. It can reach the person and support mastery and self-worth, and it can function as a catalyst to reach other parts of the brain. It can link to memory, it can link to emotions, language, and movements. So what is MBC, music-based care? It's a systematic relational approach to caregiving. And it supports recipients' well-being and improves staff's psychological work environment. Staff use music, singing, rhythm, and movement integrated into the daily care to make most of the music potential beneficial effects in a care setting. The musical activities and measures must be adjusted individually and applied systemically, regardless of the staff variation. So we have the artists who come in and give concerts, but then we have the staff who should use this in everyday care. And when we teach in the program, it's based on research and good practice, and it's inspired by several branches of music and health research. It's inspired by the neurological music therapy, by music therapy, and music pedagogy, which we combine. We build on, among others, the Gardner's concept of individualized music, using music that has been integrated into the person's life and is based on the personal preference. And it has been developed into a systematic educational program. Among others, Audun Misha, a medical doctor and PhD, has been very important in developing it. And it's also based on the person-centered care model of Kitwood. Adding some musical activities and measures in this flower gives a quick visual impression of how music can enhance the provision of these needs. Music may stimulate personal resources, which often is not activated in the care home's daily routines. The program aims to give caregivers simple but efficient music-based methods and tools to facilitate trustful relations, good communication, and meaningful activities. And this can enhance the residents' well-being and make the caregiver's work more fulfilling and less straining. So we have the continuation courses at university level, and we also offer practical courses across the country for employees and managers in health and care sector who want to learn these methods of the integrated use of music, singing, and movement within a clinical setting. And our most practical course is a 5-day course. We meet the health personnel 2 days, after a month, 2 days, and then after another month, 1 day. And they get some theory why this works with music, and then it's a lot of practical tools, so they can go home and start working on it. So when we teach the music-based care, we focus on some core elements that guide the music-based methods and the tools. So this is the content of our course. I'm going to rush through it, but you can see it afterwards. The music influence and possibilities, we go through the scientific basic of why music works. And then we have the awareness and facilitation of the sound environment. And that includes the basic understanding of the hearing loss and other sensory and cognitive impairments. Residents with cognitive or mental challenges are more easily triggered by unpleasant sensory stimuli, and thereby their alarm system is also more easily activated. They may be unable to reorient efficiently, so the consequences of unpleasant or harmful stimuli can often be more severe and more long-lasting. And it works on communication and relation. The courses gives tools to facilitate trustful relations, good communication, and meaningful activities. And then you analyze and assess the current situations. We have mapping behavior can be useful to identify when you would like to try a measure. We have schemes adapted for mapping tool for people with functional variations. And yeah, one example is a patient who wakes up 1:30 every night, awake the whole department, and you use 2 hours to get everyone back to bed. They find out this happens at the same time every night. They put on the relaxing music this person likes half an hour before, and he never wakes up. So the impact, it's so nice little measure, and the impact is so large, just to give you an example. But it's important then to map the music preferences, because me and you, we probably don't like the same melody. So what do the person like? And if they come with dementia, maybe they don't speak so well anymore, and then you need to map in different ways. We have made this very simple scheme. We rank the music: 3, that's a very favorite; 0, that's music you dislike, or in the worst case, it triggers unpleasant memories or trauma. And there are some online lists, so if your patient was born in 52, you can start trying the music from this time. But I guess that will be more difficult when we get into the elder care, because we are not so, we like very much different musics. And then how to plan and structure and carry out interventions and activities. They can be individual, and they can be in groups. I will come back to a few examples. And when it comes to rhythm, movement, and touch, inspired by neurologic music therapy principles, rhythm can enhance gait or support movements or exercise, not only in rehabilitation, but also in aging and in dementia care. For instance, the caregiver can sing easy, well-known rhythmic songs while walking with residents, or use rhythmic cues like a metronome or rhymes. Then we come to the most challenging part. Documentation, evaluation, and systematic implementation is important and challenging to get the method long-lasting in the care homes. You have routines to document every time you give medicine to a patient. And similarly, the non-pharmacological treatments should also be documented, but we see that this is difficult to achieve. If your patient should have 15 minutes of calm music every evening, and it has an effect, if you don't put it to the log, you can't prove that you are actually having an effect. And then caregivers must be aware that the needs and preferences can change due to disease development and the current state of the day, so evaluation and further development of adjusted measures may be needed. So when planning and organizing musical initiatives and activities, it's important to fit them into the daily routines to ensure that they are carried out regularly and consistently. So one example can be a resident listening 15 minutes to recorded preference music while waking up. If the caregiver also applies caregiver singing as part of the morning procedure, the residents get a good start and might influence the rest of the day of the patient. Music initiatives can also be organized before or after a meal, or as part of the evening procedure when calming preference music to induce rest. But sometimes staff also need to apply supportive initiatives immediately when observing initial signs of emerging unease. For example, a mood-adjusted recorded preference music can be played, or the caregiver can sing. It's essential to start such initiatives before the unease spills into anxiety or agitation, because prevention is far more efficient than the firefighting. One example of a group activity is to play calm and soft background music in the common area when there is a tendency of unrest in the department, such as before and during staff shifts. When residents are gathered around the table, it's easy to sing a few songs together just before or after the meal. And many institutions hold sing-along in the living room or even outdoor, for example, before noon or with the afternoon coffee. And one of our employees also just finished her PhD about singing in the private relations. So this is also working very well when you have a person with dementia in your home and you don't have so good communication anymore. You can do a lot of nice relation building with the singing. So in between the courses, the first 2 course days, when the participants get some tools and get the lectures, they should start to adapt these tools to their working situation, including mapping individual musical preferences and trying out individualized measures at the workplace. And then the second time they meet, most of the 2 days, they are sharing their experience with each other and reflect and discuss the achievements and the hinders that appeared. The peer discussion add valuable tools to each participant's non-pharmacological tools case. Yeah, here you see from a course it's quite active. And we always ask them to go for the easy challenges. They always go for the most difficult one, but still they manage so much after these first trials. It's amazing. And in the courses, we have a lot of videos which I don't show today since we are streaming it and it will be online. So I instead went to the employees and what they are saying after the course. So after learning the music-based care, Rava has new information, and she was really motivated when she got smiles from the patient as a response to the measures she was trying out. She said, we often get shared experience where coerced decisions do not need to be used when the music-based care treatment is developed. So we have quite some negative happenings in the morning care, which ends with 2 individuals having a really nice time singing together. I mean, that gives a big impact on the day for all the involved people. And Nurse Ragnhild, she said, well, the methods, they fit for everybody who work with people. And one of my teachers, she used it on her children, she used it on her husband, so you don't have to keep it in the care homes. You can use this as a mild method everywhere. It can be used to promote sleep and create focus. The staff observes improved everyday life and their patients, and now they use a different approach to them, and this really motivates the staff. And you do not need to be a musician. Anyone can use their voice and see the music can help to calm down patients who have challenges with restlessness and anxiety. Marianne here, she's boxing with residents to Jailhouse Rock from Elvis Presley. And she reflects that the activities must have both physical, cultural, and social content. It is important for the employees to experience the measures together with the residents, who must be seen and felt expected and meet someone who knows them. When she puts them into a concert, she knows who wants to be in the front, who wants to be in the back, and so forth. And trouble situations between residents have been averted by the use of music. Not only was a trouble situation averted, but the resident retained their dignity, were seen, and avoided having a bad experience due to the unrest. And then we have some research. When music-based care is systematically integrated into the care work over time, both extensive practice reports and research show that satisfaction increase, both among the users, the relatives, and the employees. The employees feel that they can work smarter and increase the quality of the care. Systematic implementation is the main challenge, and I will come back to that in a few slides. We did an RTC study to see if it was an effect of the music-based care on pain intensity in patients with dementia and chronic pain, but the effect we saw were not additionally compared to the control group. And maybe then RTC is not the correct way to measure this kind of results. In a follow-up study of focus group interviews, the healthcare workers pointed at the use of music as a positive distraction from the sensation of pain until the painkiller works. So the list of reported benefits from using music-based care is long and shows that this general method meets the starting point from our research center from the political white papers to explore non-pharmacological tools to solve challenges in the field. And the list contributes to the strategy to recruit, keep, and develop the personnel. But this is the positive list, and then the major challenges or the success criteria where they really have got this to work is support from leaders. It's really pointed out that Implementing the method over time, the leader's support is the most important, so we advise the manager to join the courses together with the employees to gain a common starting point and a common understanding of the changes needed. And the staff should feel safe to start testing out this measure. At the same time, you would expect some resistance to accept this change because it's a new working method. And maybe the method is not for everybody. We should respect that also. To play a playlist, everybody should be able to do, but to sing with your song, with your own voice, maybe takes some time for people to do. But in the end, most of them do. And then they come up, I tried today and it worked. Because you get immediate feedback. And it's nothing about having a good voice. Because you are the one caring, your voice is good enough. And of course, there's a cost at the initial phase. I mean, we say it's simple, but of course, changing the way you work, we know it takes time to get new routines. And we need someone maybe to have the evaluation and development responsibility to do it over time. So music-based care is the main project. But in addition, the Research Centre also works with other cultural expressions like theatre, arts and prescription, and promote the field in the refereed journal. And I will briefly show you some practical guides we have developed, but they are in Norwegian, so how useful they are, but at least you just know about it. We have one book we made in collaboration with the municipality and the local photography museum. We developed a practical guide for use of historical photos in elderly care. The collection gives glimpses of everyday life situations to bring recognition and associations, to start reflections and to start conversation. It is plastic laminated to survive the spilling of the coffee in the living room, and you can download the guides, but in Norwegian, from our webpage. And then Anna Helga, a visual artist and artillerista, developed together with residents and healthcare workers how to use felt to give new content, mastery, and joy into everyday life. The system of felt patterns is useful, creative conversation starter. The guide is again in Norwegian, but this one you can download and the patterns are there, so you can try it. The collages this was made at the closed psychiatric ward are still decorating the walls some years after the co-creation, and they aren't allowed to have anything else on their walls. Here is the students at the university course who tried a tool for non-verbal communication and collaboration. Is a very good icebreaker in the start of the course. And right now we are trying to develop movement. We want people to have movement, more movement into their life. And we think that dancers are good at teaching. And we want to do this in an open online film. And we are testing it now on health personals. We are going to test it on students, and it will be out, hopefully early next year. And then it will be films with no talking, so that you can use. It's not in Norwegian. We will go on with mental presence and express oneself creatively. And my time is out. Thank you for your attention.
Do we have also questions to Marit? Do we have time for that? Please feel free to raise your hand, or maybe we have something in Slido. No, Slido is empty. So, yes, it was a hand, no?
Man nav jautājums, bet man ir jāsaka, ka mēs arī izmantojam mūziku, deju.
Atvainojos, mazliet. Did you catch the translation? Sorry. You can, yeah. No, you have the translation. Okay, jūs varat sākt vēlreiz jautājumu.
Man nav jautājums, bet man jāsaka, ka arī mēs izmantojam savā darbā gan mūziku, gan deju, gan kustības un ritmu, un jāsaka, ka redzam arī šos rezultātus. Un mums bija viena kliente, kura nerunāja, kurai bija zudušas šīs runas spējas, bet dziedot dziesmiņas, kas viņai bija zināmas, viņa dziedāja līdz vai arī sita ritmiņu līdz. Tā kā tas tiešām ir pierādījies, kad šīs te visas māksla un tas tiešām palīdz.
Paldies par jūsu komentāru. Vēl kāds? Jā, lūdzu.
Man ir jautājums.
Sorry, jā, arī, jā, sekundīti.
Jā, paldies. Es gribu, mums Latvijā ir mākslas terapeita, augstākā izglītība, tātad studiju programma, un tad, protams, sadalās tādā ziņā. Tā arī ir jauna profesija, bet es gribēju par Norvēģiju tad jautāt, cik jums ir Norvēģijā, kā jūs vērtētu izplatīt šis mākslas, kā saka, aprūpes vai mākslas integrēšana aprūpē, cik izplatīta ir sociālajos pakalpojumos vai šaurāk sociālās aprūpes pakalpojumos? Kā jūs vērtētu? Vai tas ir tādā sākotnējā stadijā, vai tomēr tā ir tāda ierasta prakse?
We have music. Thank you. We have music therapy education, 2 places, and the challenge with them is that they work usually one-to-one. So if you compare all the residents, even if they work day and night, 24 hours, they never kind of reach everybody. So the music therapist I discussed with, they mostly supervise care workers over how they can use their measures. For some, like eating disabilities, for some things, the therapist is very good. But this is the core of our program, is that we should make it into everyday care. Because what happened during the pandemic, all the hospital clowns, all the music therapists, they weren't allowed into the department. And when we did this big RTC study, it was during the COVID. All the other studies shut down, but since we were training the healthcare workers, they could still give cultural measures and treatment to the residents. But there is nothing against that. We need both. And we just had a music therapist who made his dissertation, his PhD in Bergen, and one of his studies was during the pandemic. So he was supervising health personnel in our MBC method. And what we see with our method is we need someone which are more deep into understanding the method to do the planning, do the mapping, do the evaluation. And if we get a music therapist for that, that's perfect. But I also think that the therapists are some of the first positions the municipality cuts when it's bad economy, because they are not, by law, they don't need them. Yeah, a long answer.
Yeah, my question was not about music therapy, but about how widespread, how it is included in daily practice. How, in your opinion, in Norway, you're this music-based care, because I understand that I just mentioned this music therapy because it resembles a bit what are you talking about, but of course I understood that it is not the same. But how do you assess it is widespread, or it just in the beginning, or how it has intertwined into a daily social care service practice, or it should be developed more? What is your
It should be developed more, but what we see with the challenging economy of the municipalities, there are not many municipalities who can afford to have a musical therapist. And I think we just got arts therapist study starting in Oslo. So it's not widespread. That's a short question. And I think they can contribute very well. But I think we can reach much more people if we get the care workers to also use culture.
Paldies. Vēl kāds jautājums? Maybe some other questions or comments? If no, yes, then we say thank you so much. Okay, thank you. And now I think we need to conclude already today's, I would say, fruitful conference. I think there are many ideas shared and experience shared, and I heard somewhere that when we are sharing experience, we are helping other people to raise their quality of life and to change their life. And I think dementia is a very good example where we can see it. As we heard at the beginning, 55 million people facing dementia already now, and by 2050 it will be double. But the good news, half of the cases can be can we prevent? And there are a lot of things to do. Also about that we heard today a lot, and thank you for your examples. I hope this inspiration will really guide to concrete actions in national level, in municipality, local level, and also NGOs, and our very personal level when we are friends, family members, maybe colleagues of someone who needs our help. I want to ask Daina Merecka here to join me. She will be moderator of tomorrow's conference, and she's also one of the organizers of this event. Say a few words, because tomorrow we are expecting very interesting topic, because it will be about the age-friendly cities, right? And you have really what to say already about today's event.
And I would like to ask Rubenis to join me, just that we, the team of tomorrow's moderators, are here, and you see us and get intrigued about tomorrow's theme.
Hello, everyone.
As somebody, perhaps, when you saw the programs of today's conference, where some of you might have been wondering, well, dementia and age-friendly cities for everyone, why during one and the same conference? But I don't know if you noticed the same things which I noticed in Piret's story or presentation from Estonia, that you have started in Estonia, the competence center is starting to think more and more about environmental adaptations. And then before that, it was also mentioned that the hotline, it's not enough to call a hotline, just informative hotline, information and trust hotline. And I myself, I'm very thrilled about architectures and built environments potential to make, to create meeting spaces, meeting places, to create safe surroundings, to boost good encounterings, or to create obstacles for inclusive society and urban environments. And in order not to stay in my professional background is more related to social field and contact building between Nordic and Baltic countries. And therefore, I'm very happy that Rudis Rubenis, as professional architect, will be joining me, and we will lead you through the working day tomorrow. You comment something on?
Yes, maybe just a small comment of my experience today, that I, as an architect, was thrilled to see some examples, and yes, the comment about that it's actually scientifically researched that built environment can affect you positively in preventing dementia, and in this sense, because as architects, I think we've always been somehow intuitively trying to create unique places and trying to create something that just feels good, and always trying to find some logical explanations or some very practical reasons. And I think especially in Latvia and in Riga in following years, when we will have to renovate, for example, the Soviet housing where 70% of residents actually live in Riga, and we're always pushed towards, find unified ways to do it, find a product kind of approach and something like that. And it's really nice to see that there are also strong and very well-argumented reasons to actually do things more humane, and I think that's a really nice connection for me. So yeah.
Thank you. And
I think tomorrow we will have really interesting discussions and presentations. I already want to hear what will be tomorrow. But for today's, I think there's something we want to say. Thank you, right?
I would like to invite, we will thank today's speakers. I would like to invite speakers here. And while you are coming, I will also thank the participants here in the conference hall and also participants online. My colleague has informed me that there were over 100 participants listening to Latvian version of this channel of this from this conference hall, and over 100 following in English. And I can inform you that the participants both in the conference hall and online are really a nice diverse group, most from the municipalities in Nordic, Baltic and Nordic countries, and also from universities and professionals both from social and healthcare field, and also city planning and research. So please stay with us, those of you who are watching the conference online. Please return tomorrow. And for those who will be, who are here in the conference hall, we will continue with conversations outside in the lobby.
So, but we are asking speakers to come out, yeah? Please, Pia, Piret, Laura. Yes, please come as well.
Thank you very much.
So once again, thank you, speakers. Thank you, audience. Thank you for being so active and participating in today's conference. See you tomorrow, and also continue our discussions with refreshments and networking opportunities outside where the coffee break was taking place. Thank you and good afternoon.